It's very exciting to see all these young women in the audience here. We welcome you to Alzheimer's, a woman's health issue. And I am Jackie Speier, and I'm the Congresswoman that represents the 14th Congressional District where you are right now. And we welcome you here today. Now, I thought it was only fitting that we complete National Women's History Month by holding a issues summit on Alzheimer's, and I will tell you why. I was pretty ignorant. Until fairly recently, I had no idea that 2 out of 3 persons diagnosed with Alzheimer's are women. I also didn't know that 60% of the caregivers or more are women. I also didn't know that a woman age 60 is more likely to be diagnosed with Alzheimer's than breast cancer. So for all those reasons, I started to delve into the issue, and that is why we are here today. I thought it was only fitting to start National Women's History Month with the little ones. We had, when I grow up, and we had young girls from all over the San Francisco and San Mateo County hear some pretty remarkable women talk about how they've flown in outer space and led great companies and led the fire department in San Francisco. So this is your turn, or I should say our turn, because I'm right there with you. We do have some VIPs in the audience, and I'd like to introduce them. Carol Matsumoto, who is the former mayor and city councilwoman of South San Francisco. Lisa Mancini, who is the San Mateo County Director of Aging and Adult Services. And we're going to introduce Ed Ortiz because he works for the San Mateo County Health Plan and because his mother is one of our speakers. Ed, please say hello. So this is a very important conversation that is going to only increase as more and more people start to recognize that this issue is truly significant. As part of this conversation, we're going to talk to some experts who you will be meeting momentarily. Let me just help you see it through my eyes as a public policy maker. There's no cure for Alzheimer's right now. It's the 5th leading cause of death in California, the 6th leading cause of death in the United States. It takes a tremendous toll on families, on friends, on the financials of a family, and it takes a tremendous cost to the Medicare healthcare system in this country. I had one person who visited me with Alzheimer's Association just last week in Washington. Her husband was diagnosed with Alzheimer's when he was 50, so very early onset of the disease. He was an emergency room physician. And he has now been living with Alzheimer's for, I believe it's maybe 14 years. He's now in assisted living. It has taken $700,000 out of their family's financial nest egg. And now her daughter, who was quite young at the time, is now about to go to college, and they're financially strapped. Another woman told me about her mother, who she cared for 4 years. But her mother really died 4 years before her actual death in this young woman's eyes because her mother no longer knew her. Her mother threatened her. Her mother accused her of stealing from her. And it was a very painful experience for a loved one to have to endure in caring for a family member. Right now in the United States, in the federal budget, it costs about $236 billion a year to provide health care to those who with Alzheimer's through the Medicare system. That number by 2050 will be over $1 trillion. So if we want to somehow harness the resources within the Medicare system, it is incumbent on us to do something about this issue now, not in 2050. In 2015, we invested about $560 million in research for Alzheimer's through the National Institute of Health. Now, this number, when you compare it to other diseases, is frankly quite small, and we need to do more to change that. In today's panel, we will discuss basic information, early signs, diagnosis, the newest research and treatment options. And with that, I'm now going to introduce you to our distinguished panel. Cynthia Ortiz Guzman, who is sitting to my right, knows Alzheimer's more intimately than anyone wants to know it. After a 30-year career as a nurse, she was diagnosed with early onset Alzheimer on her 63rd birthday. And we are so grateful that you are here with us today to talk with us, Cynthia. To my left is Dr. Elizabeth Landverk. She's the medical director of Elder Consult, a medical practice that provides care and consultation for older patients. She will talk about the early warning signs and testing. Welcome to Dr. Landverk. To my far left is Dr. Michael Gracious. He is the medical director at the Stanford Center for Memory Disorders. He will share some fascinating research about why Alzheimer's is of particular concern to women. Welcome, Doctor. And finally, to my far right is Ruth Gay. She's the Director of Public Policy and Advocacy at the Alzheimer's Association for this region, and she will fill us in on available resources and their advocacy work, which I experienced firsthand in Washington last week. We had lots of purple sashes roaming the halls of Congress, and you made quite an impression, and it was tapped off by a hearing by Senator Collins on the issue in the Senate. Now, each panelist is going to give you a short presentation, and then we'll open it up to questions from the audience. If you have a question, there are cards that you can fill out, and then if you will pass it to your right, well, actually, pass it to your right on this side and pass it to your left on this side, and staff members will pick it up. We're also streaming this panel live on the internet. So we are truly in the technologically advanced era that allows us to make this available to so many more people. For those who are listening to it or watching it online, you can email your questions to speir.events@mail.house.gov. Now, Speier is spelled S-P-E-I-E-R. .events@mail.house.gov. And you'll see the address at the bottom of your screen. Let's start out with a perspective we don't often hear, a first-person perspective. Cynthia, you were diagnosed with the disease but turned it into something positive for others and yourself. Please tell us your story.
Okay. Thank you. I was a nurse for 30 years. And during that time, I drove between 300 and 400 miles a week, and I used to maintain my home inside and out, and I had a pretty good memory. And about 3 years ago, my brain went like a switch light. Sometimes it was on, and sometimes it was off. But when it was off, I couldn't tell you if I slept or how long I slept, if I ate and what I ate. And when I watched TV, the only thing that I seemed to remember were the commercials, food commercials at that. I was getting lost in familiar places, and I couldn't understand written or verbal information that was coming to me. And so I went to my primary physician, who had seen me for 8 years, and Because she didn't know what was wrong with me, she sent me to a neurologist. And I was in a neurologist's office within 24 hours after I went to her with my problems. And I was tested with my son Ed at my side. I was tested and I was diagnosed at that time with dementia. And I asked the doctor, explain dementia to me. And he said it was that my brain was getting older faster than my body. So when we left, we got out to the parking lot and I told my son, you know, today's my 63rd birthday and I've been diagnosed with dementia. I'll never forget that. And he said, well, I think they got the right diagnosis because they told you you're going to forget everything. So after that, I went to see, before a second opinion, I had a psychological evaluation. And so during that testing, I became very upset. And so the psychologist said, what's the problem? And I said, you know, I'm so much smarter than this test is letting you know I am. And so she told me for the rest of my life, for the rest of the test and for the rest of my life, that I shouldn't stress because that makes my memory worse, and that I was a changed person, and just to wake up and accept who I am for that day. And I'll have to tell you, I haven't waken up as Madonna yet, so I think I'm doing pretty good. So at the second opinion, because they had more information, I was diagnosed with Alzheimer's dementia. But the great part about this is that this neurologist said, next month, I want you to bring in everyone that really cares about you, and I want them to have questions. I'm going to give them your diagnosis. I'm going to give them your prognosis. And as soon as you leave our meeting, we're going to go see a social worker, because it's time for you to prepare for the rest of your life while you still have a choice. You can still make some of these choices on your own. So 3 years later, I can't do the things that I used to do, and lately worse than what it was before. But you know, my life is like a race that I won't finish because my disease is fatal. So I'm looking for people to run for me when I can't anymore. And there's no gold medals, but I promise you there will be an end to Alzheimer's. And I have a good life. You know, but it came from that first doctor that said, I don't know what's wrong with you and I'm going to get you more help. She is the core of my being able to have a good life. And some of the reasons that I have a good life is because I accept my diagnosis, and my family does also. And I have family support. My son and my son-in-law are my care partners. And because I was living in Phoenix, they moved me to the Meadows in Napa Valley. And so there I am close to family, close to the neurologist at UCSF, and I'm part of research. The facility allows me to have socialization, activities, meals, housekeeping, transportation, and the only thing I have to stress is picking my wine to drink with my meal. And the Alzheimer's Association, they have given me a purpose in life. They have given me the audience to be able to tell my story, and to advocate for funds for research and for education is so important. They have a 24-hour care hotline that you can call if you have problems. It isn't like waiting till tomorrow. You can call and somebody will listen to you. And I am the voice for the Pats who passed away way too soon, and for the Helens that are physically perfect, but their minds won't let their bodies know that they're okay, and for 5 million other people who don't have a voice to tell you that we still have good lives, but there is so much that needs to be done. And I'll tell you that, you know, when a child loses his parents, they become orphans. And when a wife loses a husband, they become widows. When a mother loses a child, it's so devastating, there is no word for it. So I'm an only child, and my mother will lose me twice. Once when I don't recognize her, and when I pass away. But that's my side of the story. I have a letter from my son Ed, and Ruth is going to read it for me.
And the letter says, "I don't want you to worry or be afraid. Let's enjoy every single day and not think too much about whether you can remember as well as you could in the past. I will watch over you and won't let anything bad happen to you. If the time comes when we need to do more for you, I will make sure you have everything you need to have a great quality of life. I wish I could change things. I wish I could take your illness for you, but I can't. All I can do is be there for you and be there for you until until the end, yes."
Your memory sounds pretty good to me.
Yeah. So as a legacy to my family, I want to be a part of a movement that educates others and helps advocate for people with Alzheimer's and their families. As this disease progresses, I won't remember anyone, but I want to live my life so that people will remember me. Thank you.
Wow, thank you, Cynthia, for putting a face on this disease and for having the courage to speak out and help us understand it more. Now, Dr. Landsverk, who is board certified in internal medicine, geriatric medicine, and palliative care, will tell us how you use your qualifications and experience to help families and medical professionals with Alzheimer's disease.
Well, thank you very much, and thank you for the invitation to be here today. And I think, Ms. Guzman, you said it all. I mean, you had a caring doctor, you had a supportive family, you had a neurologist who took your concerns seriously. I think that's the dream team as far as I'm concerned. So the symptoms, as Ms. Guzman had said, it can be trouble with your memory, but sometimes it's something besides the memory. And in the DSM-9, the diagnosis of dementia was more memory related, and the DSM-10, it is more a decline in different areas of the cognitive functioning. So someone might have their memory. A common test that we doctors use is called the mini mental status exam, and it's a 1 to 30 point test. Do you know where you are? Do you know what time it is? Can you spell world backwards? And it used to be that we would say a score above 24, you were normal, and a score below 24, you were not. And now we realize that someone could have a perfect score of 30 over 30, and early symptoms of dementia or cognitive decline could just be the loss of risk assessment. So those people still have their driving, they still have control of their financial assets, but when a scamster or someone using undue influence comes into their life, they might not be able to assess what the person is saying and whether it's helpful to them or not. And what we're seeing is a huge growth in financial elder abuse. So that is just one consequence of not having early diagnosis. And as the Alzheimer's Association had said, of those who are diagnosed, first off, 50% of those with dementia are not diagnosed. And it's important to know whether it's Alzheimer's or Lewy body or vascular dementia. We don't want to just say it's dementia. That's like saying you have cancer. Well, you want to know what kind of cancer. And of the people who are diagnosed, 48% are not told that they've got dementia. And so, this makes it very difficult because, as Ms. Guzman was saying, it's important that you have your say about how you want to live the rest of your life, who you want to help you. And, what your neurologist did was fantastic, bringing in a social worker, bringing in people in your family to explain. And I often say, well, how can I make the doctor, listen to me? I don't know. What I would say is I would look for those centers that have that approach. So I think UCSF is one. Stanford has its memory clinic. I know at the Valley Medical Center, they have a geriatric clinic. I think if you go to see a geriatrician, they're going to take a more holistic global approach than a busy physician who has been taught. And you know, no knock to the doctor. This is a new area of medicine. And I was trying to figure out why we as a culture don't recognize early dementia. And I look back, and it turns out that the average lifespan in 1965, when Medicare got started, was 61. So we didn't have that many people with dementia. So now our society is having to try and catch up. So I would say that you want to go to a center. I also do house calls and do evaluations, but you'd like to go to a center to get a clearer evaluation. So the mini mental status exam is not sufficient. There's something called the Montreal Cognitive Assessment, or the MOCA, which is somewhat better, but it's still a screen. If you have someone whose behaviors have changed, so everyone knows Robin Williams and how kind of zany he is. And I think everyone remembers Clint Eastwood at the Republican National Convention. And if Robin Williams was doing that performance, well, you know, maybe he was just being a little extra zany. But for Clint Eastwood, and I'm not saying that any of them had cognitive problems, but that seems to be out of character for what we thought of as Clint Eastwood. I would say that, you know, if someone has a change in their behavior, they're much more angry and paranoid, they're more disinhibited, and they're loving and trusting to strangers, which they've never done, then you want to go and get them evaluated, and they probably need to have neuropsychologic testing, not that the doctor thinks that they look okay, or even, you know, a number of psychiatrists and neurologists and internists can have a sense of how someone is, but the neuropsychologic testing gives you the more complete data for someone who has more subtle symptoms. And it's kind of like if we thought someone had cancer, you know, I wouldn't be just patting the belly and go, I think you have pancreatic cancer. We would do a CAT scan. And so neuropsychologic testing is a more detailed evaluation of those symptoms. Then, as Ms. Guzman was saying, it's important that you don't just say, okay, you've got dementia, here's your Aricept, we'll see you in 12 months. You need someone to help you process, like, what does this mean? And you want to make sure that you identify those that you trust, that you figure out, okay, am I safe driving? I need to have, for myself, what makes life worth living? And when I'm working with a family, that's the first thing I ask them, is what makes life worth living for you? And then you work to find those people that will honor it. It may be your spouse, it may be your children, it may be a friend or someone else that you trust. This is not the time to, you know, worry about disappointing your son who's got an alcohol problem with not giving him, you know, your finances. You have to think about who is likely going to honor your wishes. So you have that talk, you have that team, and then you want to see elder law attorney, so you can put your wishes in writing with an advance directive, and figure out, you know, what you need to do for your will and trust. In fact, everyone in this room should have done that, because there are some pretty nasty battles I've seen with families regarding dementia, but I think the national battles that we see are not for an older person with dementia, they're for the Karen Ann Quinlans, it's, you know, for the Terry Shivos of the world, someone our age who has an accident. So this is good planning for all of us. So you get your affairs in order, and then you keep engaged. The other thing that's hugely important is that you stay involved in your church or your synagogue or your mosque, that you enjoy, if you enjoy gardening, stay gardening. We don't have a silver bullet yet, but it's very exciting to me that the evidence shows that the things that we do to keep our heart happy keeps our head happy. So talk to your doctor. Most people can take a baby aspirin to cut down the risk of strokes, particularly after the age of 60 or 65. And also exercise has been shown to decrease the rate of progression. So that's what I'd like to discuss with folks, is it's not that there's nothing we can do, we just have to wait and watch everything drain away from us. If we exercise and take our baby aspirin and stay cognitively engaged, you don't have to do computer program, tests if you don't want to, or puzzles. You should be doing what you enjoy, something like ballroom dancing, something like engaging with children, engaging in your church. Those are ways to keep your brain in good shape. And then the other sorts of resources, Ruth Gay will discuss. The Alzheimer's Association is the folks that you turn to. It's just like, oh, what do I do now? There is also Teepa Snow, who has a number of approaches to engaging your loved ones with dementia. And Family Caregivers Alliance also does a really good job with support. Thank you.
Dr. Gracious, you run the Center for Memory Disorders. So what's a patient going to expect when they come to be evaluated there?
Right. Well, first of all, thank you, Congresswoman Speier, for putting this panel together and taking on this important issue, and for the advocacy that you do for funding for Alzheimer's disease. The typical workup at the Stanford Center for Memory Disorders, like at UCSF and some of these other specialty centers, I should start by saying is not that typical for the greater community, and it's challenging. And I think when you're thinking about fundraising or raising funds for Alzheimer's disease, thinking about this broader set of needs that patients and families face is important. Not just basic science and clinical research, but social support, nursing support, psychiatry. So at the Stanford Center for Memory Disorders, we have that sort of a multi-pronged, multidisciplinary approach where we have a team of neurologists, psychiatrists, nurse, neuropsychologist, and social work help. And that, I think, helps us deal with the sort of many contingencies of Alzheimer's disease beyond just the medical. But that's very expensive, and that's, in the day-to-day medical world, not really a sustainable model. It's something that universities are able to support through funding from research, for example. But that's critical, I think, for helping patients and their families deal with this issue. So what we do when a patient comes to see us, a new patient at the Stanford Center for Memory Disorders, they'll start with the neurologist typically. We'll take a pretty thorough history, about 25 or 30 minutes. We'll do a neurologic examination, which often includes the MoCA, the Montreal Cognitive Assessment that Dr. Landsberg mentioned, as well as a pretty thorough neurologic examination, sort of head to toe, looking for things that might point us towards or away from Alzheimer's disease. We almost invariably have the luxury of referring the patient then for a formal neuropsychological evaluation, and this is a 2 or 3 or sometimes 4-hour endeavor. We give you breaks in the middle, and you can get lunch. But this is a really exhaustive look at all the different cognitive domains and how you stack up for people of your age and your educational background. So we can really say this is where this patient should be performing, and if they're below that by a standard deviation, then we're concerned. And I mention that as a luxury because, again, in the community setting, it's not often that doctors have access to this sort of support. But that's, as low tech as that is, it's basically pencil and paper testing. It's really one of the most sensitive measures that we have. After the neuropsychological testing, we'll typically follow up with some routine blood work. We check everybody for B12 and thyroid because those are reversible causes of memory loss and dementia that we want to make sure we don't miss. And then everybody gets a brain scan, either a CAT scan or an MRI. We generally prefer MRIs, but a CAT scan is sufficient. And this is mainly to rule out things like tumor or stroke. There is no brain scan currently that diagnoses Alzheimer's disease in a positive way. These brain scans are really to rule out other possibilities. So at the end of that, we sort of gather all this information together, and we make a determination. First of all, does a person have a dementia? It's sort of a confusing term, and Dr. Landsberg touched on this a little bit. Dementia is sort of a generic umbrella term. It means somebody's had enough cognitive decline that they can't run the show on their own anymore. But there are a bunch of different causes of dementia, some reversible, like I mentioned, others not reversible, like Alzheimer's disease or multiple strokes, for example. So do they have a dementia? And if it's a dementia, which dementia do we think it is? Alzheimer's statistically is almost always on our list because it's so common. But there are some other less common dementias that we encounter and that we have to sort of rule in or rule out also. So that's a sort of basic workup. And then I was going to say a word or two about research. I like to sort of be optimistic about things too. And with the help of the NIH and the Alzheimer's Association, there's a lot of very compelling research that's underway these days. One thing that I didn't touch on in the workup is something called biomarkers, and this has only recently hit the clinical stage, but a lot of us are getting used to thinking about these. So biomarkers are things that give us a better sense about the actual underlying pathology. They're tests that we can do, and they come in two flavors. One is a PET scan, which can tell us whether or not a patient has amyloid in their brain, amyloid plaques in their brain. And the other is a lumbar puncture or spinal tap, and that lets us measure the amounts of amyloid and also a second protein called tau. I mentioned these are just sort of hitting the scene clinically, but they've been around in the research domain for the last 15 years or so, and we're really getting a better understanding of when Alzheimer's disease starts, sometimes 15 or 20 years before a patient shows symptoms. And what's really nice about that is it's now allowed us to start to go after this disease in what we call the preclinical stages. So rather than waiting to try an experimental treatment when somebody's already got a mild or moderate dementia, let's move forward 5 or 10 years when we see the earliest signs of Alzheimer's disease with these biomarkers and intervene at that point. And the hope is that these therapies will be much more effective when we get in earlier to the pathological process. And so there are a lot of big studies underway now, again, sponsored in part by the NIH, by the Alzheimer's Association, and actually by industry as well, to test this hypothesis. Can we pick this up before people get sick? Can we intervene with an anti-amyloid treatment and see if we have a better chance of affecting the course of disease at those earlier stages? And I think these trials are going to finish up, in the next 2 to 4 years, and we're going to learn a lot about basic pathology of Alzheimer's, but also whether these innovative new approaches are going to pay off. And we're pretty, cautiously optimistic.
Great, thank you, Doctor. So, Dr. Landsberg, you had one other comment you wanted to make before we move on to you, Ruth?
I did, thank you. So I was cognizant of trying to keep it short, but I also wanted to mention in my work, what I often find problematic is medications can make people look like they have more dementia than they actually have. I've had several folks who have ended up sick in the hospital on a bunch of medications, end up in a dementia facility, and then I work on their medications, and it's only like 5%, but there's a number of folks that really didn't have dementia. And the other thing that is a little shocking, and I'm sure Dr. Grisha sees, is our pill culture. So basically, I spend 60% of my time getting people off of what they call benzodiazepines, or things in the Valium family, and Xanax is the crack of benzos. Do not let your loved ones use it. The sleeping pills, Ambien is really still problematic, and so those medications can make someone look more confused and more dopey, and often they can exacerbate, as you were saying, your friend's mother was threatening and accusing. That can be from the disease. I know that there is one faction that says, well, this is only just behaviors, and if you take care of all the needs, then you shouldn't have any behavior problems. Well, the disease itself can cause people to be paranoid and angry at those that are trying to help them, and medications can make that look worse. So I would say at my website, elderconsult.com, there's a section on the psychoactive medications. It's just general. You should not use it to change your medications yourself, but as a starting point in discussing with your doctor. I would say no Ativan, no Xanax, no bladder pills, no Unisom, no Tylenol PM.
No Tylenol PM?
No. Well, Since I do house calls, I can have not only the list they give me, but then I go into their medicine cabinet and see what's actually there.
All right, okay. I'll have you over soon. All right, let's move on to Ruth Gay, who is the Alzheimer's Association advocate locally and did a great job advocating in Washington last week.
Thank you, Congresswoman Speier. It's a pleasure to be here. Cynthia was with us on the Hill this last week, and I think one of the things that's very interesting to me when we start talking about Alzheimer's disease is how it touches such a nerve. When we were in Washington, D.C., and we had on the purple sashes, as you described, they said Alzheimer's Association on them. I have to tell you, people came up to us that were strangers that said, thank you for doing what you're doing. I think Alzheimer's, one of the challenges and the impact of Alzheimer's disease is that it's been so silent, right? People sort of disappear from the scene when somebody develops Alzheimer's, and not just the individual sometimes, but the caregivers as well, right? When we bring people together to talk about how to change the spectrum of what happens for people with Alzheimer's, they're always surprised to see how many other people are touched by this disease. So I just want to ask you all, how many of you in the crowd today have been touched by Alzheimer's? You have somebody close to you, a family member, a friend, somebody that you know?
How many have not?
Very few, right? And this is true across the country. I think one of the things that we have to believe is that we have to understand this disease better, and we have to change the trajectory of what's happening with this disease. Because too many times, as Dr. Lansbert said, less than half of the people ever get a diagnosis. And if they're not diagnosed and they don't know what they're dealing with, how do you get on the right medications? How do you get the best possible care for your loved one or for yourself? When we talk about Alzheimer's disease, it is very definitely a women's issue. Women are almost twice as likely to develop Alzheimer's disease after the age of 60 as they are to develop breast cancer. And when we talk about this in circles of people of all ages, of adults of all ages, it is by far the most feared disease. HIV/AIDS was in the 80s. We've come a long way with those diseases. And now Alzheimer's is the most feared disease. And I can tell you, when I work with families, when I talk to adult children, the elephant in the room is this what's next for me? What do I do to reduce my risk as we go forward? So when we begin to talk to Congress, and I know when we start talking about legislation, people's eyes glaze over, but I'm going to talk just a little bit about some of the things we're trying to change and we're trying to do so that we can change the way we see Alzheimer's disease across the spectrum. We have to change the way care is delivered. We have to make sure people are getting a diagnosis. We have to engage the government in increasing research funding for Alzheimer's disease. Alzheimer's disease research funding falls at a fraction of other diseases, and I think you're going to talk about that, so I won't go into that very much. But we need awareness and education. We need people to understand what it means. I was in the hospital recently with my mother-in-law, who can neither see nor remember to push the button and to call for somebody. I can't tell you how many times I was counseled by the staff that she must push that button, or we were going to have a sitter in to sit with her 24/7 because she had to push the button if she wanted care and support. She couldn't get out of the bed without help. The challenge is that she didn't remember the minute the person left the room that this button was something she should push. We have to change the way people understand and interface with Alzheimer's disease. We need to create a movement to influence change. Alzheimer's disease, I could use it, that'd be great. Alzheimer's disease is by far the disease that has been silent for too long. Look at all these slides. And what we know right now is that when we hear from the National Institutes of Health, they tell us we are not at the moment limited by ideas. We're not limited by scientific opportunities. We are not limited by talent. We're limited by the resources and able to move this along. We have to invest in Alzheimer's disease today if we don't want it to bankrupt our nation in the coming 20 years. This last year we have had success. The government passed the Accountability Act. Congresswoman Speier voted for and signed on with this bill, but it allows the National Institutes of Health to submit a special, independent, professional budget to Congress saying, if we are going to have a cure for this disease by 2025, we need this amount of money to do so. Before anybody can market or red mark this budget, they get to see what it's going to take to advance our understanding of Alzheimer's disease. The Hope for Alzheimer's Disease Act is going forward, and this year, right now, we're asking for co-sponsors on this bill. It is bipartisan legislation, and it's a Medicare package. It says if you get a diagnosis of Alzheimer's disease, the doctor must provide or connect you with care planning. Cynthia had a social worker with her. She had best practices in how do you go forward living with this disease. Every family should have that when they get a diagnosis. And in addition, it asks the doctor to document the diagnosis so it's in your medical record, so the hospital knows, so that your other specialists know that they're talking to somebody with Alzheimer's, and maybe we need to alter the way we provide information for this person. It also asks Health and Human Services to take a part in educating physicians about how to diagnose and best practices in what to do once somebody is diagnosed. This is a huge area of gap for families. We are asking this year for Congress to push for $300 million in Alzheimer's disease research. I can tell you, even with $300 million, we still fall far below other diseases. But it would put us on the right path towards advancing our understanding of tau research and biomedical research and precursors and the things that would help us understand earlier diagnosis. We know that at the rate we are spending for Alzheimer's disease today, which is in the billions of dollars in care and support, in Medicare and Medicaid costs, we spend $100 on research compared to the $26,000 that is spent on care. We cannot afford this equation if we go forward. There is a bipartisan congressional task force on Alzheimer's disease that we ask every member to participate in. We know that today we need a game changer. We know that we need people to step forward and speak out on this disease like Cynthia has. We know that when people participate in research, and there are many ways to participate in research, both as normal participants and as people who are leading the charge for trying new diseases, we can make a difference. The Alzheimer's Association provides an array of services. Cynthia alluded to our 24/7 helpline. It's available. People can talk to somebody any time of the day or night, and they get a social worker or a specialist. We have an array of programs and services for families that are free for the most part. And we have advocates in Washington, D.C. stepping up and speaking out about Alzheimer's disease. And I'll stop right there.
Thank you, Ruth. Okay, as the staff collects your questions, I'm going to just show you 4 slides to put this in perspective for you. All right, this first slide shows what us baby boomers are going to do to the population with Alzheimer's. By 2050, it's going to double the number of people with Alzheimer's. The next slide shows you the cost to care for almost 14 million people with Alzheimer's in 2050. And that figure, as you can see, is $1.1 trillion. Right now, it's costing us about $226 billion. Now, this one is astonishing. Since 2000, we've seen a significant decrease in the causes of death from other major diseases, such as breast cancer, prostate cancer, heart disease, stroke, and HIV. The only one that you see up there that is going in the wrong direction is Alzheimer's, and it has increased by 71% in terms of the number of deaths associated with it. And this kind of tells the whole story. This is how much money is being spent on Alzheimer's versus how much is being spent on cardiovascular disease, HIV, AIDS, and cancer, various forms of cancer. And as Ruth pointed out, if you had consulted with me before you did that ask for $300 million, I would have had you double it. Because we've got to get the attention of the policymakers in order to address this. Francis Collins, who Ruth mentioned, is the head of NIH. He's a brilliant man, physician who is responsible in large part for the whole Human Genome Project. Really remarkable. Spent over 20 years doing that. He was invited to China to see what they were doing in that regard. And in an old shoe factory in one of the provinces, they had 3,000 scientists looking at his work and advancing it. And he said that within 3 to 5 years, they will have eclipsed all the work that we have done in the United States. That's how much more money they're investing in research than we are, and that's why it's got to change. Okay, now we have questions. Okay, the first question is to me. We should keep this for the... What is your sense about the current level of commitment and support for increasing funding, finding a cure among your congressional colleagues? And what specific actions are you committed to champion as it relates to these two goals, increasing funding, finding a cure? Thank you for hosting this. She had a cute little note at the end with a smiley face. Okay. So I think co-sponsoring every bill that the Alzheimer's Association is promoting. But I'm actually thinking of doing something a little more bold. And it just came to me in the shower this morning, actually. When breast cancer was being ignored in terms of health research, a group of women led by then Congresswoman Barbara Boxer were successful in getting funding not in the budget you would think it would go in, not in the science budget, but in the Department of Defense budget. And since I serve on the House Armed Services Committee, I'm thinking of offering an amendment during the National Defense Authorization Act this year to augment what you've already asked for, to expand on the research that's being done. I recently was at a company that does a lot of work on antibiotics, and I asked them about Alzheimer's research and what they were doing. And his comment, the CEO's comment was, you know, there's been a lot of money spent on it by companies independent of federal dollars, and they just have come up against a brick wall. And without the federal dollars, the research in Alzheimer's will not continue. Okay, Cynthia, from your personal experience, do you feel there is a stigma around Alzheimer's disease?
Oh, definitely. Definitely, and it's because of lack of education. I went to the hospital and to the emergency room, and I talked to 6 professionals, and I made it clear that if I didn't understand what they said, they had to go slower because I had Alzheimer's. all 6 of them said, "You don't look like you have Alzheimer's. You look fine, except that you're sick." And so, am I supposed to look like a certain way? Am I supposed to be in that wheelchair before people will recognize me as a person that has Alzheimer's? And the other thing is, why would you want to say that you have it if you look okay? But that's what's wrong with me. That's why I have to say it. And people will always tell me, "I feel so sorry for you." Then I have to tell them, I don't clean, I don't work, I don't have to worry about driving, I just worry about my wine. Why are you telling me? Do you have even 2 of those things on your list? So, yeah, I want to change that. That's what I'm working for.
Thank you. So this question's for the 2 physicians. I have a family member, late 70s, female, experiences memory issues. She exhibits symptoms of denial. She has seen a primary physician but refuses to see a neurologist. How can we convince her to see a neurologist?
Well, there's several approaches to that. Sometimes we go around, I do house calls, and often when they won't see the psychiatrist, they won't go to the memory people, I'll go in and talk to them, and sometimes, I can't even bring my stethoscope, but I'm just like asking them, how are things going and what's going on, and what kind of medical problems do you have? Do you take any medications? And so I ask them questions to kind of figure out where they kind of are, and then I can help the family figure out the next steps to that. I mean, I always love when I can get folks to a center. Also, the Institute on Aging has neuropsychologists that come out to the home. So we often run into folks who just won't go and get evaluated because they're scared. Or also, folks, it's not always that the elder has denial. It might be that they have what's called anagnosia. They don't know that there's anything wrong. That often happens with vascular dementia. And that person is fine. They don't need anyone help. They don't need anyone in their house. And you are crazy, and go home. So there's several different ways to get to the truth.
Yeah, and I just said, as a neurologist, we're not that scary, but I do understand people's hesitation. And one way to get a lot of information, sort of a backdoor route, would be to have the primary care doctor refer the patient directly to neuropsychology. And that can be done through places like Stanford. So you can sort of initially at least skip the MD specialist, but get to the heart of the matter through neuropsychology evaluation.
The one thing I'd like to just point out there.
We're going to go on with some more questions because otherwise we're not going to
It's just that if you have legal issues at Stanford, they haven't done the forensic stuff. So.
Okay, so there's a series of questions. Ruth, let me just get these out and then you can comment. There's a series of questions on research. How can you find out about the clinical research trials so we can be part of them? What currently is the most promising approach in research that can translate into treatment? Please comment on the new research identifying Alzheimer's as a metabolic disease, as some researchers are calling it diabetes 3. And please discuss hereditary, specifically mother to daughter, and recommendations for taking vitamin B12.
So just those 6 questions then?
Yeah, right.
Okay. So first of all, it's very, maybe the first question to tackle is how can you help out? This is critical. So a lot of Alzheimer's research is done in a mouse model or various mouse models. We call that Mouseheimer's disease. We've cured Mouseheimer's disease 1,500 different times now and still haven't landed on a definitive treatment. Human research is what my group does, and the mouse work helps a lot, but at the end of the day, we care about the human disease. And so getting healthy controls, getting people with mild memory complaints, getting patients with Alzheimer's disease to volunteer for these studies is crucial. The Alzheimer's Association has some referrals for that. If you go to Stanford's neurology website, we have an updated list about clinical trials that people can partake in. UCSF has the same thing. UC Davis There are several big Alzheimer's centers in the extended Bay Area, and we really need people to help out. You don't have to be sick to help out. You can be, like I mentioned, a healthy older person who we follow every 6 months or yearly. We look at these biomarkers in those sorts of healthy subjects. It's a delicate sort of issue, but having human tissue to do research on is really critical. And so this sort of reluctance that people have in talking about brain donation is something that we are eager to overcome, because I can't tell you how valuable it is to be able to look at the brain after the patient has died under a microscope and really get a ground truth about the diagnosis. I'm probably going out of order here, but diabetes 3. So there's no question that there's a lot of overlap between diabetes, and probably mainly it's linked to vascular disease. So people who have diabetes are more prone to having small strokes in the brain that can contribute to a dementia, and so there's a lot of overlap between Alzheimer's disease and vascular disease, particularly in people that have diabetes. It's also possible that diabetes independent, separate from the vascular disease, has more of a primary role in triggering some Alzheimer's changes. That's ongoing research work, which needs to get done, but is still a little up in the air. Let's see, mother to daughter. So a lot of my work these days is on the genetics of Alzheimer's disease. The most common and potent genetic risk factor is something called ApoE, and particularly the ApoE4 gene. This is present in about 50 to 60% of Alzheimer's patients. It's very important right off the bat to point out that the run-of-the-mill person worried about memory should not get ApoE testing done. It's not a yes-no gene. It's a risk factor gene. But it looks as though the effect of the ApoE4, that's the risk ApoE gene, is more potent in women than in men. So if you have 2 copies of this gene, whether you're a man or a woman, your risk for Alzheimer's are greatly increased. But if you have 1 copy and you're a man, your risk doesn't bump all that much, whereas if you're a woman, it bumps about 4-fold. And this is something that we're really intent on trying to figure out. In terms of mother-to-daughter transmission, there's another sort of more complex set of genes that get passed through what we call the mitochondria. Mitochondria are passed only from the mom to either her daughter or her son. And so that's a direct maternal transmission. We haven't actually seen a mitochondrial gene linked squarely to Alzheimer's disease, but that's another avenue of research. I'm probably too short, Congresswoman. Two questions short, I mean, here. I don't know if I didn't cover.
A pretty good job. Some of these are repeated. Okay, let's ask this question of Cynthia. You're involved in the movie Alice. Still Alice, can you tell us about that?
Yes, the screenwriters called me. Well, first they made a call to the National Alzheimer's Association and asked if they had people that would be willing to tell their stories. So I talked to a screenwriter a couple of times, and when you go see the movie, my name is on the credits at the end.
Did you get to go to the Academy Awards?
No, and I didn't win one either. So, but what's funny is that I went to see the movie, and we were going to be on a panel after the movie, but people started moving out, and so I'm sitting there waiting for my name to come out, and they cut it off because they were afraid that the people wouldn't stay, so I've never seen it. So.
Okay.
Oh, and I had my picture taken with the lady who wrote the book, Lisa Geneva, at the forum in Washington.
Oh, very good.
Yeah.
Okay. So this is, again, for the doctors, and let's start with you, Dr. Landsberg. Any nutritional, this is an internet question, any recommendations for nutritional supplements to slow Alzheimer's, aerobic exercise, frequency, duration, intensity to slow Alzheimer's? Besides a statin and a baby aspirin, what other agents do you recommend for vascular dementia? What agents are you using for patients with bradycardia? Bradycardia?
Bradycardia. So there are tons of nutraceuticals out there. There's vitamin E, vitamin C, and basically nothing has panned out. Not ginkgo biloba, not vitamin E. Basically what I recommend for folks, I'm even more crunchy granola, fruits and vegetables, and get out the door. I think a plant-based diet is probably better than one heavy in fats and meats and dairy, and that it would be very nice if there was something that we could just all take. What I do give my patients is I give them vitamin D because I want them to have strong bones, and I want their muscles to be strong so they have better balance. I give baby aspirin. And statins, I definitely give for folks in their 70s and early 80s, but when they get near 90, actually the studies have not shown that they're helpful, so I actually often take them away in the 90s. And so, Dr. Grecius.
Yeah, and then just the bradycardia question. So bradycardia means your heart rate is too slow, and the most commonly prescribed medicine for Alzheimer's is donepezil. The brand name was Aricept, but thank goodness it's generic now. This is a minimally efficacious drug, to be very clear, and it can exacerbate bradycardia, particularly in older patients that are on beta blockers, which a lot of older patients take. So I think that was probably what the bradycardia question was about. I recall now that I'd forgotten to ask or answer the question about B12, which sort of ties into this earlier. B12, it's very hard to become B12 deficient. We don't recommend supplementation unless you actually have a blood level that suggests that you're low. And I think the bottom line response both to nutraceuticals and also to the software programs that, to their shame, KQED still advertises, is that none of this has been proven to work. And if you're going to spend $400, a year on this stuff, give it to the Alzheimer's Association. That would be my recommendation.
So, Doctor, I actually fell for that KQED offer. It won't. That's what I thought. It won't hurt me. Okay, Ruth, here's one for you. My wife was approved for Medi-Cal long-term care benefits while at a large long-term care facility. She had to be moved to a board and care facility because she needed more personalized care. Board and care is not eligible for Medi-Cal benefits. When will this change? The message for Medi-Cal is, we recognize you need help, but if you need too much help, we're not helping.
That is such a challenge, and one of the gaps in funding issues is that, just as you say, when somebody is in a hospital or in a skilled nursing facility, certainly Medicare will pay for a period of time for those skilled needs, but it will run out, and unless you're eligible for Medicaid at that point, but it will not cover assisted living or 6-bed board and care facilities at all. And that is an area we're looking at and working on. California actually has an assisted living waiver that they have been going forward with. It's in about 6 counties now, or 8 counties right now, but funding has been such that it hasn't really expanded in the ways we'd like to see. So.
Okay. This is a question again from the internet. My mom seems to be the most alert in her care home, socializes, is aware, but she seems to not want to chew solids anymore since in the last month. Even pureed foods, doesn't like the taste or the texture. She does drink chocolate high-protein boosts. Other folks chew and swallow, but not her.
Well, anytime someone has trouble chewing solid food, I want them to see the dentist. And there's a few geriatric dentists that will make house calls. So that would be the first thing I'd want to know about. I would worry about their neurological situation and how their swallow works. They might have had a small stroke that affected that, and Dr. Grecius can speak to it more. And then one thing I'm famous for is, as folks progress in their disease, if they don't want to eat anything else but ice cream, I give them ice cream. So I'm famous for the ice cream diet, not for people like me. But I think as folks progress in their disease, we need to find the kind of food that they like. And if they only want to have ice cream, that is okay.
Let's go back to Tylenol PM for a moment. Is that a sleep aid that people who are, not yet diagnosed, maybe getting older, maybe having trouble sleeping? Is that something you do
In
not
Congress?
recommend?
Yeah. What I would say is that, I remember when I was in training, we used Benadryl to help folks who were on the alcohol detox ward because we thought it was safer. And I know that a lot of people think that it's safer because it's over the counter. I actually took a picture. I went to the pharmacy. There is a wall. There are like 8 different kinds of Advil PM, Tylenol PM. It's probably not okay for anyone. We have to also watch out for the bladder pills. My aunt used to like to go hiking, and she'd like to take her Detrol because then she wouldn't have to urinate for her 5-mile hike or her 5-hour hike. And that made her have more trouble with her memory, as well as gave her constipation and dry mouth. So I would say it's not a good treatment for anyone.
Dr. Gracious, I think you had some comments earlier. I didn't want to make.
Oh, no, I just echoed Dr. Landsberg's comments about over-the-counter medications. I actually made the mistake of taking a Benadryl last night, and I'm still operating on about 8 of 12 cylinders. And that effect takes a much heavier toll on somebody that already has some even mild memory trouble. So they really should be avoided. And there are some gentler alternatives that you can speak to your physician about. Yeah, but generally less is more in terms of those sorts of medications.
Okay. Let's see here. This is kind of a repeat. Well, actually, Dr. Gracious, tell us about your research on women, Alzheimer's, and menopause.
Right, so menopause is an incredibly complex issue in terms of memory loss and memory disorders. And if you followed the literature or the lay press over the last 10 or 15 years, you're probably as confused as we are. So we used to recommend estrogen replacement. The big Women's Health Initiative and Memory Study came out suggesting that estrogen and progesterone replacement actually increase the risk for dementia. And so now we don't recommend it routinely. So it's an incredibly complex set of questions. It turns out that this ApoE gene, the most common genetic risk factor for Alzheimer's disease, its expression, how much of that gene or protein is around, is very dependent on estrogen. So estrogen can sort of ramp up or ramp down the amount of ApoE that's expressed. So we were pretty confident that at menopause, when estrogen levels plummet, there's probably a big change in the amount of ApoE that's around. So that's part of what we're looking at now. The other big issue with the hormone replacement trials is that most of the big ones anyway all looked at hormone replacement in women age 65 and older. The mean age of menopause is 50 or 51, and that 15 years between 50 and 65 really has not been explored that carefully, and that needs to get done too, I think.
Okay. Ruth, this is a question for you. Has any developed nation come up with a good approach for treatment, medicine, home care? Of course, many, not us.
Right, many. And actually, for home care and for services, many other countries have really, especially if they have universal health care, have really focused on that aspect of keeping somebody at home and better caring for them. Australia has a wonderful model. Israel, Japan is looking at a dementia-friendly community and looking at ways to allow somebody to still remain within their community, knowing that people can support them in that, and it's like a village support system, not just the family support system. A lot of interesting models out there across the world.
Is there any correlation between bladder infection and Alzheimer's dementia?
Well, that actually is a discussion that could take an hour by itself, but I won't do that, I promise. It is true that as elders become more frail or their memory declines, having a bladder infection could be life-threatening, can make them look really angry and paranoid, or can make them really lethargic. And so if someone is having those behaviors, you want to make sure it's not a bladder infection, but you also want to make sure it's not a pneumonia, because someone could have dementia and have a pneumonia without coughing, which is really scary. And so you want to treat those before you reach for the Haldol or the Seroquel for the bad behavior. The flip side is we're realizing that and this is more a doctor's issue, that we doctors overdiagnose bladder infections with dementia, that maybe just 10 or 20 white blood cells in the urine, particularly if it's a not clean catch, can be pegged as the cause of the behavior when it's really not. And that's dangerous also because we're getting a lot of drug-resistant bacteria and Clostridia difficile, which is a C. diff antibiotic-associated diarrhea that is life-threatening to frail elders.
I think that covers it nicely. I would just add that it's often the case that either UTI or the flu or any systemic illness takes a patient that might just look pretty good on the day-to-day with mild Alzheimer's disease, and like Dr. Landsberg said, makes them look much, much worse. So really one of the first things that you should think about for your loved one, if there's a sudden change in their behavior or in their cognitive capacity, talk to the primary care doctor, think about the urine, think about systemic infection.
And I just wanted to add on the one thing that we doctors might not be as good at as identifying pain as a cause of behavior as well. And I like to say that, you know, dementia does not cure arthritis. If someone took naproxen for 5 years for their arthritis and then they don't complain about it but they get more irritable, there's studies that show if you put them on Tylenol standing several times a day that can decrease the agitation too. So getting rid of the bad meds, treating any infections, and getting rid of pain gets you a long way.
Okay, what kind of test should I ask my doctor for, and why are they so reluctant to give me that test?
Well, so you have to be a little careful what you wish for, right? And this is becoming more of an issue actually with this press ganey sort of rate your physician. We're getting a lot of pressure from the administration to make sure that our patients are, you know, satisfied with their visit and with their workup. And what this will drive a little bit of is unnecessary testing. So I already mentioned ApoE is a gene test that I would not recommend anybody getting unless they've already seen a neurologist or a geriatrician, they have some symptoms and there's an indication for it. But a lot of physicians and centers will offer ApoE genotyping, which puts somebody in this challenging position of having a risk for Alzheimer's disease when we don't have a treatment or a curative approach to it yet. Similarly, there are a number of sort of scientifically invalid imaging centers. I'll just go ahead and mention the Amen Clinic. I've got nothing to lose here. This is out-of-the-pocket costs to get these fancy colored blob brain images that have absolutely no bearing on Alzheimer's disease or other cognitive disorders. So there are a lot of tests that you ought not to get. The list is too long, but I think meeting first with your physician and going over the sort of information that you expect to get from a given test is the most helpful way to approach it.
Dr. Gracious, talk a little more about the Amen Institute, if you would, because some people probably don't know about it. If I remember correctly, he started out looking at PET scans and drug addiction.
Yeah, so I'm kind of already on the record. I know you can't erase your Google history, and I guess I should just go with it here. So the Amen Clinic is a series of clinics throughout California, and I'm afraid even further afield now, that uses a various degree of imaging tests, PET scans, SPECT scans, which are really quite outdated, to come up with really a colorized image of your brain. And so people with children with autism or depression or schizophrenia go to these clinics and get these reports back, but these are completely scientifically unsupported. We give the insurance industry a lot of grief for the stuff that they don't fund, but the insurance industry also knows what has some return on investment in terms of funding, and they uniformly do not reimburse any of these scans that the Amen Clinic does, and for good reason, because they're really completely unjustified. So I would strongly recommend people not to get that sort of imaging done.
Could I just add one thing, not about the Amen Clinic, but about getting the tests done that you want to have done? Recently, about a year ago, Medicare now will cover a screening exam for people 65 and older on cognitive abilities. A lot of times I think people have to ask for it. We haven't gotten to the point yet where we do a cognitive screening in the same way as we do a blood pressure check. We need to, but we haven't. But you can get a cognitive screening paid for as part of your healthy wellness check at 65 and up, and that should, if there are concerns or risk factors identified, allow you to be referred to a specialist or onto one of the clinics for more comprehensive workup.
One, in terms of tests that you shouldn't have done. The other one that's going to sort of be coming online and become more of an issue is this amyloid PET scan. So this is now FDA approved, and I think for good reasons. It turns out that about 30% of healthy people over the age of 70 will be amyloid positive on these PET scans. And we think that's actually true positive. When you look at brains under the microscope, when people have died, about 30% of people over 70 have amyloid plaques. This does not mean that you want to go out and get an amyloid PET scan done. One day in the near future, with the help of the NIH and the Alzheimer's Association, we'll have preventative treatments for Alzheimer's disease, and then everybody will get their amyloid PET scan at 55 like they get their colonoscopy at 50. But we're not there yet. These tests come with a lot of uncertainty in terms of what to make of them. They're also not covered by insurance. Typically, these amyloid PET scans are out of pocket, and they cost about $3,000. So I would not recommend those unless your physician has recommended it for memory problems.
So Cynthia, tell us about your typical day and when you find yourself, or just tell us about your typical day so that we can get a sense of how you're living with Alzheimer's.
I don't have a typical day.
But tell us about yesterday then.
Yeah, that can't happen either. Some days I get up and I'm not a regular breakfast eater, but if I do, usually talk with people and they find activities that we're going to do for the day, like going to the show or going shopping, going out somewhere different to eat. And I'm kind of the rover of the community. I'm walking all over. I go visit everyone in the different buildings, but I don't have a regular day because sometimes when I wake up, I don't remember what it is that I wanted to do. And people say, well, write it down. Well, I can't remember it long enough to write it down. And then someone said to put it on a tape recorder. Well, I lose my phone 3 or 4 times a week, so a tape recorder would just be something else for me to lose. But I don't have a regular day. I make sure I go down for the meals so I can socialize, and I go on trips and I go shopping. But I don't have a regular day. I go exercise when I can wake up to go because I love to sleep. If I could sleep, I would sleep all the time. And
Are you taking any of those sleep meds?
No,
okay.
No. And as I've progressed, I find that sleeping comes very easy. I go to sleep quite a bit lately.
Let's see here. Someone wrote Exelon patch efficacy. Is that?
As Dr. Grecius had said, the anticholinesterase inhibitors, so just a really quick point about dementia, is as the neurons die, they don't produce as much choline, which is what the nerves use to talk to each other. So anticholinesterase inhibitors make the choline increase, which is why we don't want to take Tylenol PM, because that makes it decrease. And just saying. And the Exelon patch, one of the problems, as Dr. Grecius had said, with the donepezil or Aricept and the Exelon is that it can have GI upsets. As a hospice medical director, I found a number of folks who were on Aricept, who were on hospice, who weren't eating, and I'd have this discussion with the family that, you know, you're going to die faster if you don't eat than if you don't take your medication. For some folks, it can stabilize. I've seen that it can stabilize behavior, and I often get called for complicated situations, difficult behavior. And the patch is nice because then you don't get the GI upset or the diarrhea or the appetite effect that you might get from the Aricept or the Exelon tablets, but it can affect balance. So if you're older and frail and you have poor balance, the patch is not a good idea.
Okay. I have a relative in a care facility. All patients seem to be sedated. Is this common for Alzheimer's as a method to control multiple patients with reduced nursing care?
That is a hot button issue.
That's why I gave it to you.
Well, thank you. So I would say there are factions very much against using any antipsychotics in dementia. And the fact is, I think they're coming to the point where they're not going to be paid for by Medicare. But there are a few people that need some to help their quality of life, such as this woman who was threatening her daughter and was accusing her. If someone is really angry and aggressive, or it's really impacting their quality of life, I think we should use a small amount of medication, but only as long as needed, and that is not one of the medications I start with. I would say, since OBRA 87, 30 years ago, that no one should be sedated, full stop. That everyone should have the right to their consciousness during the day, and that we need to find better ways to address this. And I think that we doctors need to step it up. I'm not looking at you, I'm just saying we doctors need to step it up and make sure that we're aware of this. I've heard that someone who's on Seroquel of 175 milligrams, well, it's just end-stage dementia, but we have to recognize that, sedating medications, and on my website, elderconsult.com, under medications, it has about the psychoactive medications, what medications are sedating, and no one should be sedated.
Yeah, and I mean, I generally agree with all those comments. There's unquestionably a time in some patients' clinical course where, particularly, less so in the facility setting, where ideally there's staff, and you can use behavioral workarounds, increase the staffing on those patients that are having more behavioral trouble, and maybe pull it back a little bit from those that aren't. Where I tend to use low doses of antipsychotics for brief periods of time is more in the setting where the family's working hard to keep a patient at home, particularly if it's a single spouse caregiver and the patient is a male and they're large and they're still healthy. There's a risk for people to get hurt, and so in those situations, I think we would all agree reluctantly that there's a role for these things. But like Dr. Lansford mentioned, it should be start low and go slow, and also revisit the issue every few weeks. Can you start to pull back on these? Because as the disease changes, people's tendency to act out or be physical will also change on its own, and it's too often the case that the dosing or being on the medicine at all doesn't get revisited.
One thing from a policy perspective on that, there's a movement across the country that is looking at the use of antipsychotic medications in skilled nursing facilities. And there's a push to either eliminate or at least drastically reduce that. And skilled nursing facilities at this point in time have a lot of reportability around using antipsychotics. The places that do not, interestingly, are the assisted living facilities, and they still do and have often a lot of usage of antipsychotics to manage behaviors. May or may not be appropriately done, and certainly there are huge issues around this, but it's an area that's being looked at on the policy arena as well.
My mother, 98 years old, and her doctor diagnosed her as having dementia and possibly a little Alzheimer's about 6 years ago after a stroke. Can she be tested at this age, be diagnosed, and be treated to improve her condition?
Yeah, that's a great question. So we're very careful about not giving in to ageism, right? The one thing that's tough with a 98-year-old is that most of our neuropsychological normative data, the mean score for people of a given age, end at about 85 or 90. So we'd have a little trouble, placing this person. But by all means, they should be evaluated. There are potential reversible causes of cognitive trouble in 98-year-olds, just like there are in 68-year-olds.
Okay, Cynthia, here's kind of a double question for you. What practical planning advice would you give to a person with Alzheimer's? Why don't I give you that one first, and I'll give you the next one.
Well, I think acceptance is the main core of us, having problems, to say that you have a problem. I like to say that people are like, if you went to the Grand Canyon, I'm going to put all these chairs in a row, and I'm going to put a doctor and the caregivers and the people that love them, and they're all sitting there. And the person with Alzheimer's or the person with having problems is walking towards the edge, and they're all saying, there's something wrong with her. And she's saying, I know there's something wrong with me, but I'm still walking. They all know there's something wrong, but they let her walk. And then she falls off the cliff. And they said, why didn't we do something before this? And it's knowing that you can do something, but it's accepting, everyone in the plan has to accept that there is a problem.
So what advice do you have for professionals working with families?
Oh my gosh. Well, first of all, don't give us that you have this disease that's fatal and there's nothing I can do for you. I've heard some people say, do you really want me to write that down, that that's what's wrong with them? And the other is like giving a script saying, come back in a year. You can't do that to us. You got to help us. And maybe it's, if you don't know how to help us, get us help from somebody else. And having these clinics, like where the doctor works, you know, having these resources on hand to say, you know, maybe you should go here. They can help you. The Alzheimer's Association, get them some social work. But it takes a whole team to be able to help them.
By the way, from Florence Marchik of Redwood City, adult day service programs offer respite for caregivers and socialization stimulation for persons with dementia. So another program to look at as well. One last question for you, Cynthia. You said that there are some things you can no longer do. Can you give examples?
Handling money is hard because when I go to, I used to do the checkout by myself. I don't seem to be able to find the place to put the money anymore, so I can't do that. I haven't drove for a long time, and I don't think I could do that anymore. And it was at my, I stopped doing that.
Do that as opposed to having someone.
And I don't think I could cook anymore, but I wasn't a good cook before anyway, so I just that. I know
me
it'd probably be
both.
worse.
Okay, thank you. Has anyone on the panel seen the documentary about the use of music to help people with Alzheimer's?
I haven't seen the whole documentary. I've seen the YouTube clips, and I mean, I think they're fabulous. It's a way to help energize people who might be lacking energy. There's one thing we understand reasonably well about Alzheimer's disease is that it tends to attack most recent memories earliest. Later memories, including memories that, as you probably experienced, if you know someone with Alzheimer's, memories that go back decades are relatively intact until very late in the disease, and that includes music. Music also tends to have a sort of direct route to the emotional centers of the brain, and so I think it's interesting to me that it took us this long to sort of happen upon this. I think it's a really completely, obviously safe, no side effects, and should be explored in all patients, I think.
A mom who's 86 years old has a diagnosis of stage 5 Alzheimer's. She was given the MOCA test not in her natural language. Now DMV is taking her license away, and her mom is very angry and upset. What questions should we be asking? Mom drives better than a lot of people.
Oh, that sounds like something I run into a fair bit. And usually it doesn't come from the family members. Usually it comes from the person themselves saying, I'm fine. You know, that my rearview mirror just disappeared one day. I would say that the testing needs to be done in your language, the native language, because that, or if someone has been here for 30 or 40 years and knows English quite as well, then you can do English. But otherwise, and I know that the MOCA is in several other languages, and I'm sure at Stanford they have access to all of that. When it comes to driving, I have a very low threshold to say, you need to go have a driving test. If someone looks pretty good, I'll give them the benefit of the doubt, but it is such an issue of public safety. And with, you know, the plane crash that we just had, I've run into, you know, even as an internist, I've had to look at someone who has seizure history and they're a bus driver, and I'm like, no, we can't do that. So I don't often say, well, if they look good, they're functioning fairly well. I won't often say, well, you have dementia, you can't do this. I'm going to say, you need to get tested to see if you actually still can do it.
Yeah, this is a big issue. It's a challenge in the clinic. The last thing you want to do after, giving somebody a diagnosis of Alzheimer's is say, oh, and by the way, before we finish up our visit today, I'm going to let the DMV know about your case and you can't drive. And it's never that cut and dry. There is a state law that mandates that if we make a diagnosis of dementia, we, the physician, have to send this note in. For I think, important public safety reasons, it's a law that makes sense, but there's some nuance to the law, as Congresswoman Speier understands, and there's some flexibility built into this. And so if somebody has a very mild dementia, I'll typically say, may still be safe to drive, needs to be evaluated by the DMV. There was an alarming study about driving in dementia showing that 50% of people in the mild stages are no longer safe to drive. Interestingly, in that same test, there was a large percentage of healthy older controls who were also deemed unsafe. So it's a challenging issue.
The younger population and the teenagers are also. Okay, we're going to have to bring this to a close. Really outstanding questions. The panelists have done an extraordinary job of putting a face on this disease, but also providing you with lots of good advice on what meds you shouldn't take and what you should be looking for. I want to just end by answering a couple of questions. One was by someone who said, well, now that HIV/AIDS is almost under control, why can't we take the money away from them? This is not about taking money away from any other disease. It's about making sure that those that are focused on Alzheimer's, and that as a Congress, that we recognize that we have got to raise the funding to Alzheimer's to what is being provided to many of these other diseases, and become as strong advocates as the HIV/AIDS community was in getting funding for HIV. And then one question said, we provide so much funding for young people and youth programs. Can't we create more balance for Alzheimer's? Let me make something very clear. We spend far more money on the senior population than we do on the younger population. So it's not that we're balancing one interest or another, but the over 65 age group gets extraordinary support in terms of Medicare, for once. Everyone thinks they pay in enough money to Medicare and that Medicare is there for them. As Dr. had pointed out, when Medicare first came into being, it was thought that we were going to live to be 61, and we're living into our 80s with great vigor. So it's not about taking from one and giving to another. It's about recognizing that we have to provide more research and more focus on Alzheimer's so that we can address the long-term impacts financially and the short and long-term impacts on the individuals who are diagnosed with it and their families who are providing the care. So thank you again for your attention and for being part of this.